Hello and welcome to today's presentation around how do you measure growth. So some objectives for today's lessons: being familiar with a growth chart and being able to reliably plot, have an understanding of interpreting a growth chart, knowing how to accurately measure a child and an infant, and understanding which equipment to choose and how to calibrate it. And really the most important of all of these aspects is pulling all of these together and knowing when to refer. The format to the content is as follows: an introduction, something around growth charts, choosing the right equipment and how to calibrate it, and then how and when to measure occipitofrontal circumference, length and height, and weight. How to plot these measurements, including target centile ranges and mid-parental heights, looking at body mass index, and again, as said on the previous slide, knowing when to refer with a practical quiz at the end for you to test your knowledge. So a community objective of measuring is very much to refer patients and knowing when to refer into primary care for further investigation, with the hospital objective being to see the children and to investigate concerns surrounding their growth. And it's never okay to just say a child isn't growing. We could do with some sequential measurements, ideally 3 minimum. Need to look and think about how old the child is. Are they veering away from their centiles, either upwards or downwards? And what's the parental height? We get a lot of referrals for short stature in the hospital setting, but in fact, if we had questioned in community practice first of all and perhaps measured ourselves and plotted parental height, these unnecessary appointments wouldn't happen, because actually it would appear that some of these children have genetically short parents as well. It's safe to say that a parent's worry is correct until you prove otherwise, and whilst it might seem like a really easy thing to measure a child, actually it's incredibly difficult to do it well, and it's also extremely important for some of the points raised above. So looking at normal growth, children gain approximately 25 centimetres of growth in their first year, and this is evident from a baby in arms to a child, say, on their first birthday. And this growth is derived from nutrition and the thyroid hormones. Growth hormone plays a part from a little later in life up until the time of puberty. So children grow on average between 4 and 8 centimetres a year, and this is classed as their childhood growth. And then children obviously hit puberty, and their puberty and their growth is delivered via the sex hormones, LH and FSH, and they get their pubertal growth spurt. And boys on average are taller than girls by about 13 centimetres and can expect to gain about an additional 25 centimetres during puberty. And this is just to give you an overview of a growth centile chart. We use the Child Growth Foundation 9 centile cross-sectional reference growth charts. They're endorsed by the Department of Health and the Royal College of Paediatric Child Health. And they're updated whenever new data demands or at routinely 5-yearly intervals. And these new WHO charts were introduced in approximately 2012. So you can see this is just an example of a boys chart. The girls chart is in pink, and ever so slightly different height centiles, because obviously we know boys grow differently from girls. But the top measurement is the head circumference, or the occipitofrontal circumference, and you'll see further on in this presentation how best to measure that. Obviously there's the length, and then there's the weight, and we talk about length up until the child is 2 years of age, and then that translates into height, because they move from having their length measured laying to their height measured standing. It clearly shows us the age of months and weeks along the horizontal axis, and it's broken down into units of 10, which helps make plotting easier. And again, we'll look at decimal aging a bit further on into this presentation, but essentially there's a calculation that can be done to take the child's year of birth and do a mathematic calculation based on the day that they're actually measured in the year, and it gives you a digit that can be plotted more easily than an age over a 12-month period. And unlike the historical charts prior to the use of these ones, there's now provision for plotting length on a preterm chart for children born less than 35 weeks. Weight values run up the right vertical, and height and OFC measures run up the left vertical, all in centimetres. So for both height and weight, the bold central line here indicates the 50th centile. This is average for the population, and what this tells us is if somebody is sitting on the 50th centile, there will be approximately 49 children taller than them and approximately 49 children shorter than them. And children fall across all types of centiles for different reasons. So this dot here demonstrates the child on the second centile. So only about 98 out of every 100 children will plot higher than this centile. This individual here, if you stood them in a line with 100 children of their exact same age, they would be towards the bottom of that line, and 98 of those children would inevitably be taller than them. So what about equipment for measuring height? This is a Leicester height measure. It's a plastic piece of equipment, is used regularly in clinical ward areas, and it's been designed and improved to allow accurate measurement to the nearest 1 millimetre, which is crucial for mainstream growth monitoring, and it has the advantage that no calibration is required with a meter stick, and it's easier to use, it's transportable, it folds down into a carry case, and it doesn't have to be calibrated each time that it's used or moved. This is unlike the Harpenden stadiometer, which is a piece of wall-mounted equipment that's incredibly expensive and very heavy. It's a wall-mounted counter recording instrument, and it's got an effortless counterbalance movement, so it rolls down really smoothly and rolls back up again. It gives very accurate and direct reading to the nearest millimetre, but it does require daily calibration with a meter stick. So this is the sort of equipment you'd see in a specialist measurement department within a hospital. A measure mat, it's lightweight, it's portable, it's non-stretch and non-shrink again, so it gives accurate measurement, and it's designed for measuring the length during the first year of the infant's life in a clinical setting or on a home visit. And it's to provide length as a comparator to weight, but it's not suitable for research when a supine device measuring to the nearest millimetre is required. You need something a little bit more sophisticated than this for undertaking such measurements. The rollometer, again, is lightweight, portable, non-stretch, non-shrink, it's hygienic, can be wiped down with medical wipes, and it's also appropriate for research, field-based, hospital-based research, because obviously it's very accurate to the nearest millimetre. And just as you can see here, the baby does have a nappy on, but actually it's desirable to measure infants that are nude to prevent abduction of the hips with the nappy in situ. This is just done for photo modesty for the internet. Equipment for measuring the OFC, the occipitofrontal circumference, with this happy chappy. It's not very often that children are this happy for you to measure this for them. It's a reusable lasso that isn't single patient use. They're sold in packs of 10, and they are the most appropriate equipment to be used for doing this. They're paper thin, non-stretch, non-shrink plastic, and they should be used in place of a tape measure, because that is completely inappropriate and isn't the correct material and may shrink or stretch, so you get inconsistent measurements. And we should take the average of 3 readings, and further on again there's a video for undertaking this. Measuring weight, we now use EU approved digital baby scales. They must carry a specific green M label to demonstrate that it's approved. They must be able to be calibrated, and they must conform with EU legislation. Obviously that means that they're costly, but a lot of settings have them now, and this was introduced a number of years ago. You can have sit-on or stand-on scales, again must be able to calibrate, and it's best practice to do this daily. And to do that you can use a set weight, so a bag of Ceylan, a bag of pasta doesn't have to be anything more complicated than that. And sometimes these pieces of equipment have a remote reader which allows the measurer only to see the weight, particularly if you're offering some discretion to your service users. So how and when to measure? It's been a hot topic, it remains a hot topic, and it's greatly debated. The National Service Framework for Children 2004 and Health for All 2003 documented a specific health promotion programme for measurement, and likewise the Child Growth Foundation have a recommended growth monitoring programme, and they are an absolute go-to website for anything regarding growth, its measurement and equipment. They are a charitable organisation that work with health services to promote accurate measurement and the importance of recognising when a referral is needed. So a really good go-to resource. So this is a chart demonstrating how and when to measure between 0 and 1 years. So these are the types of measurements that will be undertaken postnatally by health visitors, midwives, etc., going up to about 15 months of age. This shows when measurements are taken in children aged 1 to 5 years. A lot of work around school entry now, but it's really important, although these are the preferred timings, it's really important as health professionals to listen to parents and take on board any concerns they've got and responding as appropriately, something around the gut instinct and making them feel that they're being listened to. It certainly won't do any harm to do an additional measurement if the parents have concerns, and obviously if you've got concerns you would be considering earlier measurement anyway. So why do we measure the OFC? To look for micro or macrocephaly, and its ideal is to undertake 3 measurements within the first 3 to 6 weeks of life, and these can be plotted in the baby's records. So post-delivery, first home visit, and probably at the 6-week GP check. Shouldn't measure directly at delivery, but allow sort of 24-30 hours after birth for the head to reshape and recover from the trauma of birth. And try and make this the first measurement you undertake in a full series of auxology measurement of a child, because to do it on a distressed infant is incredibly difficult. So while you've got them maybe asleep or they're happy, take that measurement, and that's one less to worry about because they may become distressed. As I noted earlier, we use the lasso. We take 3 measurements, take the mean, and then the average of all 3 measurements. You may see that the OFC passes up through the centiles. Some questions to ask yourselves: has this child got big-headed parents? Are they developing hydrocephalus? If you've got concerns, refer appropriately. And likewise, we need to monitor for microcephaly. Although there isn't any treatment for such, it's just having that plotting history for future measurements is really helpful. If we've documented that it was an issue early on in life, it can continue to be monitored further on so people don't panic. There's a video demonstration here, and you can click that link which will take you to the video of an infant having their OFC measured. So why do we measure length and height? Well, we do it at birth, so we've got a marker for where the child is starting out, and this is particularly important in preterm babies. Dysmorphic syndromes and deficits might not be identifiable at birth. So actually, if we've got accurate measurement and the child then begins to develop features, we can look back at those measurements and see if they're continuing to fail to grow or grow excessively. If the child is small for gestational age, so that's a child who is born at term, we know the baby is term, but actually they're very small for a term baby. And in combination with weight, the length and height measurement allows us to calculate body mass index measurements. So how do we measure length? As I mentioned earlier, children up to the age of 2 should be measured supinely, so laying down, recording the crown to heel length using a roller meter measure or a measure mat. Once the child reaches the age of 2, they should be measured standing, unless of course they have a disability that doesn't allow them to do this. It's important to explain the procedure to the parents and the carer, and as I alluded to earlier, no nappy because it abducts the hips, and also no socks or hats because of course that's going to build millimetres on the child's length. Flat surface ideally, and use your parent to be the second pair of hands or another professional to hold the crown of the head at the top of the measurer as you bring the heels down to the plate for accurate measuring. This is a nice side photograph that shows you something called the Frankfurt plane, and it's about keeping the alignment of the lower socket of the eye in line with the centre of the ear, and therefore you're measuring the absolute top of the head. You bring the footboard up to the heels and you try and keep the feet at a 90-degree angle. Little babies and children will have the temptation of automatically trying to bring their toes forward and push the base away. So there's something about the grip on the knees and pushing securely down on the ankles to bring that plate up to keep the feet at 90 degrees. Always measure both legs together, obviously not individually. You may notice some hemihypertrophy, which could be an underlying diagnosis of Beckwith-Wiedemann syndrome, which increases, for example, the risk of a malignant cancer called Wilms in the child. Read to the nearest completed ½ centimetre, not millimetre, and if you're anything like me for remembering numbers, write it down immediately and then move on to your next measurement. Again, there's a video link here which will take you to a credible video of why we weigh babies and how we weigh babies, toddlers and children, and the things to consider when we're doing that. Again, full explanation to the child and family who you're about to measure their child. It can be done in a hospital, clinic, home setting, and if it is, and you can allow some modesty, you can get the child down to their underwear. In a school setting, we try and do this using minimum clothing, for example, a skirt and a shirt. If the parents there, make use of them, get them to hold their child's feet down so the children don't rise up on their heels, which they have the temptation to do to make them appear taller. A good trick for seeing that is to take the children's socks off so you can actually see if they're raising their heels. The feet should be together, the heels at the back of the foot plate. Unfortunately, on the stadiometer, as you can see in this picture, there are feet printed on it on an attempt to encourage the child to do this correctly. Also, having your child in minimal clothing allows you to do a quick surveillance with your eyes, looking at the whole skeleton. You can screen swiftly. You can look for non-invasively for rashes, obesity, anorexia, stretch marks, hemihypertrophy. Anything else that causes you concern, you can do that. And again, maybe having an alert ringing in your head if parents decline to do that and strip their child appropriately. So making sure the legs are straight, their bottom is against the vertical, their shoulder blades are against the vertical, and their arms are nicely down by their sides. Making sure that they've got good firm contact with the skull. Obviously, we have to have respect for religious articles such as turbans, and we would measure as normal, documenting that fact for all of the populations, but we should remove hair grips and bobbles if they're just accessories of fashion. Again, we think about the Frankfurt plane. Even when we're measuring height, we put fingers on the mastoid process and we read off to the nearest completed millimetre. Write it down immediately so you don't forget. Don't be tempted to ask the child to take a deep breath in because they'll almost certainly raise their heels at the same time and therefore your measurement will be inaccurate. But if you just gently tilt your child into that Frankfurt plane, you will see the stadiometer measure rise because you are measuring from the absolute tallest point of the crown of the head. The stabilizers on the stadiometer allow you to rest it on a vertical wall or a radiator. As I said earlier, there's the picture of the feet at the base to encourage standing not only with their heels towards the back, but also standing in the right direction. A number of children approach the stadiometer facing the wall, so we get them to turn around. And there's a red marker on the calibration these days as well to indicate the minimum height for new car seat laws, which is also a useful tool for educating parents in a clinical setting. It's easy to assemble, as we said earlier. It comes in a carry case and each end has a coded symbol and colour to allow you to remember which way it should fit together. And you can bring the calibration down to eye level to ease measurement reading. So if you're measuring somebody who's taller than you, you can tilt the whole thing down so you can read the accurate measurement without having to stand on a chair and put yourself at risk. So points to remember regarding measurement: we should really use the same person, the same piece of equipment or the same style of equipment at a similar time of day with a tolerance of 3 millimetres. So for example, our endocrine clinics in a clinical setting that the children come to will all be in a morning or in an afternoon. So we've got them at a similar time of day, because ultimately we do lose height during the day. And a good way of adults for us to recognise that is when we get back in the car at the end of shift and driving home, we might have to alter our rear view wing mirror, because actually we've shrunk a little bit over the day, and we just need to adjust that. So these are the things that we should be trying to achieve to ensure that we're getting accurate measurement each time. We plot with a dot. Measuring isn't just the be all and end all, it's half the package. Accurate plotting is paramount. It can give you very specific information about a subject as well. You can rapidly estimate the expected genetic potential of the subject by plotting the parents' heights, and this is something that happens in growth departments within clinical settings. We get both parents and we measure them as accurately as we can, and then we've got something to monitor our child against. As I said earlier, it may just be that the child has short parents and that they're following their target centile range. However, if we get a referral for a child who's suspected to have short stature and we measure the biological parents who are genetically much taller than their child, then obviously that would ring alarm bells and define further investigation. Commonest referral is exactly for that, short stature, but this one measurement by itself probably isn't terribly helpful to many. We need that minimum, ideally 3 sequential measurements so we can see what's going on. It may just be that they're having a delayed puberty and actually we're waiting with them to jettison upwards into their pubertal growth spurt. So whilst this child's height here is sitting below the 0.2 centile and they will ultimately be much shorter than their peers, this is their target height here, this is their father, this is their mother, and we know that actually this child is well within their target centile range, and therefore we would just reassure and observe growth, but there isn't anything to do genetically or treatment wise because this is purely based on the child following their parents' heights. There are calculations that can be done. These calculations are found on the growth charts themselves, so you can work them out, and we can plot that mid-parental height. So when we're observing and looking and interpreting growth charts, we can see if this child is a long way away from it or indeed achieving it. And this is the calculation that can be done for girls, and it's slightly different for boys. And as I say, these are actually on the growth charts themselves, so you can do that calculation and have it available to you. Again, this demonstrates that mid-parental height is very important. Without it, this measurement is meaningless to us. It's showing us that a child is sitting between the 2nd and the 0.2 and 9th centile. What's normal for them? There's no further measurements, but if we go ahead and measure the mid-parental height, we can see actually this child is growing below their genetics, and therefore we might want to think about making a referral appropriately. So just some plotting pointers as a summary. It's extremely useful to have sequential measurements. 3 is better than 2 because one of these may be plotted incorrectly. It's important to have heights for both biological parents. I keep stressing biological parents because it's very easy for us in clinical practice to say, is this mum, is this dad? It may be that he is seen as dad because he's had involvement with that child from a very early age, but unless he's the biological father, that's going to maybe skew what we're seeing on a growth chart. We plot with a single dot, not lines, not crosses, no dot to dot, particularly not PC, but pink charts for girls, blue charts for boys, making sure you're plotting on the appropriate style chart for the child's sex. And check you're plotting the measurement and age along the correct axes, the measured parameter vertical, age, and the horizontal. And plot using corrected age up to the age of 2 years for prematurity. So what this means is if the baby is born at 36 weeks and came to us at 16 weeks, we should be plotting their measurements at 12 weeks on their chart. Calculation for BMI here. It's the most suitable parameter to define overweight, and there are age and sex related preferences available to us. So it's weight in kilograms divided by length stroke height in meters squared. Again, this will be available to you on growth charts as an aid memoir. So this BMI chart is the WHO BMI chart that's used in many clinical settings, and it's agreed by the World Health Organization of a measure of thinness and fatness, but it's not a measure of body fat. And the red area here, this shading here, indicates a healthy BMI range of between 19 and 25. The two black thick lines here, so one here and one here, are the International Obesity Task Force definitions for paediatric obesity and overweight respectively. Though of course we'd need to err on the side of caution with those if we've got a very fit athletic individual who may fall above these lines. So again, it's that questioning about what they're doing, their lifestyle, their diet, etc. BMI for age 5 to 19 years, these are the interpretations and cut-offs. So for overweight, it's greater than 1 standard deviation or equivalent to a BMI of 25 kilograms per metre squared at the age of 19. Obesity is greater than 2 standard deviations, and thinness is less than 2 standard deviations, and severe thinness less than 3 standard deviations. So both extremes considered there. So when should we be referring? Every girl who appears to be short for her age and which falls out of her target central range should have her karyotype, otherwise chromosomes, checked as screening for Turner syndrome, regardless of whether they may appear phenotypically normal. It's some young girls with Turners don't look like they've got Turners phenotypically, but of course we need to make sure that that's not an underlying diagnosis it's going to be missed, because if we don't get to know that, they will end up inappropriately short as they grow and develop if they're not picked up appropriately. We need to refer if the child is inappropriately short or tall for their parents' height. So when we plot, if they're plus or minus 2.5 standard deviations outside their centile range. If the child is growing at an inappropriate rate, so if you've perhaps got a 4-6-year-old young girl or young boy who is charging upwards through the centiles and is very tall for their peers, may indeed have some identified secondary sexual characteristics such as breast development or pubic hair, they should be referred for suspicion of precocious puberty. And if the child falls 2 centiles below or 2 centiles above their target or genetic range, they should be instantly referred. Whilst it may just be completely normal, there is a possibility that they might have an endocrine upset, endocrinopathy, and need investigation by the appropriate teams. Possible diagnoses are given here for short and tall stature. There's a number of those that you may have heard of and those that are new to you. So there's some issues around growth delay, chromosomal abnormalities, intrauterine growth retardation, very rare and abnormal endocrine problems such as Russell-Silver syndrome, Noonan syndrome, growth hormone deficiency, Cushing syndrome. As well, there might be some dysmorphic syndromes, and just those children who, as a result of chronic ill health, aren't growing. So children who perhaps have been exposed to significantly high doses of steroids for Crohn's disease, cystic fibrosis, asthma, and even eczema if they're using lots and lots of steroid-based emollients, etc. All of these patients get referred into the endocrine team for further investigation. For inappropriate tall stature, there's a number of syndromes, so Marfan, Soto's and Klinefelter's, and again the endocrine one being precocious puberty that we alluded to earlier. If there is precocious puberty suspected in a young boy, they would automatically be referred for an MRI scan to look for a hamartoma, which is a non-malignant brain tumour but is usually the causative effect of precocious puberty in some boys. Really important take-home messages: short and fat is much more likely to be an endocrinopathy than short and thin, because growth hormone deficiency, hypothyroidism and Cushing's all make you fat. And here's some MCQs for you to work through, which will be left on the Blackboard site as well, just to test your knowledge from this presentation. So I hope that's been useful to you in understanding the importance of accurate measuring, accurate plotting, interpretation, knowing when to refer. And on this site as well, I've posted a number of supporting documents, and in the reading list online as well, some links to the RCPCH and the Child Growth Foundation, which will help pull all of this learning together. Any questions, pop them on the discussion board and I'd be very happy to answer those for you.